Tonight we're to talk about white spot lesions that are affecting the teeth following orthodontic treatment. Most of us would say that we don't see white spot lesions on the teeth after we take the brackets off, but I'm afraid it does occur from time to time, and we'll see a bit about it. As a bit of a background, the researchers here tonight, well, there's a team as well that I think Denise will introduce, or make mention of them anyway. It's a part of the team of the CRC for Oral Health Science, the Cooperative Research Centre, and a number of these exist and are in operation throughout Australia, one of them being our CRC for Oral Health. And I think a lot of dentists and orthodontists are probably unaware of their existence, which I think is a great pity. And you'll notice now in the newsletters that little articles are starting to appear there to acquaint people with the existence of the CRC and what it's doing, because the work is quite extraordinary. These CRCs operate mainly under federal finance in the region of some millions, and I think, Gilda, our first allocation was in the vicinity of $23 million. So, and that was to be utilised over 5 years. And it's a collaborative group of people. It's a collaboration between the academics, the universities, Melbourne University and Monash University, and commercial interests like GC Corporation, Cadbury Schweppes and CSL. So that the idea is that the research centre the research group would work on the research, and then rather than lose that there would be some commercial utilisation of that research. And with that, royalties come back to the university. And that, I think, has been a great breakthrough. The only problem is that we've got to resubmit for our next bout of finance, and that will occur at the end of this year. So a lot of work goes in that regard as well. And the research at the CRC for Oral Health is being directed at 4 basic programs, which I won't go into, but one of them tonight that we'll hear a bit about is on the utilisation of CPP-ACP, or Recaldent, which is the commercial name. But I won't go into that because I'm two people here and a lot of other people in the room that know a lot more than I do. So to start off, I'd like to introduce Denise Bailey. She tells me that she's a POM with some connections with West Africa, which is quite exciting, I think. But she's a senior research fellow at the School of Dental Science at Melbourne University, and she's the clinical trials project leader. And we're going to hear a lot more about our clinical trials of the CRC in the future as well. So tonight we'll start off with Denise. Would you take over?
Well, good evening, everybody. Firstly, I'd like to say how much we appreciate you taking the time to come and listen to us tonight. Being based at the CRC, we tend to be a little bit research focused, and it doesn't really mean very much if the results that we obtain aren't disseminated to the people that it affects. So it's really great to have this opportunity to present the results of our trial to you and to be able to answer your questions, hopefully. But I'd like to start off by talking a bit about the background and the rationale for the study and how it was conducted, and then I'll hand over to Professor Mike, who will talk a bit more about the results. So just a little bit about the background of the study. We're all aware that the prevalence of white spot lesions in patients undergoing fixed orthodontic treatment is higher than in the general population. How high it is a little bit unknown. A review by Mitchell said somewhere between 2 and 96%, so it's a bit of a varied subject, but it's perhaps a bit less well recognised that the majority of these lesions don't resolve in the 6 months after bracket removal. There was a recent study by Van der Veen that reported that the majority of white spots, about 61%, actually remain stable in that 6-month period, whilst another 10% actually progressed further. And although there's lots of reports in the literature about preventing and managing white spot lesions during orthodontic treatment, there's not so much research on the interventions for white spot lesions in post-orthodontic patients. So what we wanted to do was look at the effect of tooth mousse on the progression and regression of white spot lesions in a post-orthodontic population using a randomised control trial, because there's no data. I'll just present the team to start with, because some of them are here tonight. Obviously, there's myself and Mike in the back who were the principal investigators. And on the far side, I should use my little pointer, I suppose. Let's see if I can get to work. Claudine and Anne, who are here tonight, they were both our clinical examiners. We embarked on a programme of trying to recruit people into the study. It was a little bit difficult in Victoria because there's quite a high uptake of tooth mousse anyway. So we approached orthodontic practices in the area, and we had a poster in the waiting room with a a severe example of white spot lesions. The study was conducted within ICH GCP guidelines, followed the national statement, we had ethical approval, and all patients and their parents gave us informed consent. For a patient to be included in the study, they needed to have at least 2 white spot lesions on the buccal surfaces of teeth, 4 to 4 on the upper and the lower. Those white spots had to be at least 2 millimetres squared to be included. But we did have to exclude some patients. Anybody who had caries through to dentine in these teeth, we excluded them because we felt they needed more intensive treatment, so they were referred back to their general practitioners. Anybody with a milk protein allergy, and anybody who was using a medication where the major side effect was xerostomia, they were also excluded from the study. So we ended up with 45 subjects. They were adolescents between 12 and 18 years. And we recruited them from private orthodontic practices in and around Melbourne. I think there was 9 practices altogether. So we had 23 subjects in the intervention group and 22 in the control. Tooth mousse, I'm sure you all know about it, but it's an easy to apply. It's a water-based cream, and in Australia it's only available through dental professionals. It contains recaldent in about 10% weight per volume. The way the recaldent works, in a really simple sentence, the peptide stabilises calcium and phosphate ions, preventing their transformation into the crystalline phase, and maintains a supersaturated solution with respect to enamel. The CPP-ACP has been shown to prevent demineralisation and promote remineralisation in animal models, human in situ trials, and also a large clinical trial. We tested this against a placebo cream. Now, we had the placebo cream manufactured by the same manufacturer as the tooth mousse, and it was identical in every way except it had no CPP-ACP. Following bracket removal, it had to be within 7 days of bracket removal, we brought the subjects into the clinic and we did their baseline examination, and then we sent them home with a de-identified cream. They didn't know which one they were on, and they were asked to put the cream on twice a day after normal oral hygiene practices, about 1 ml, just using a finger, and just swiped it over those teeth. They were also supplied with a fluoride toothpaste and a toothbrush to use during the study, and all subjects received a 900 part per million fluoride mouth rinse at each assessment visit. This is just a picture of what they would receive each time round. They had a few movie vouchers if they came back each time, and that helped to keep them motivated. So our main assessment of efficacy was taken from the clinical assessment results. We did assessments at baseline, 4, 8 and 12 weeks. And our measure was the change in the clinical assessment score from baseline to 12 weeks. And we measured the white spot lesions using ICDAS criteria for both severity, as in how deep the lesion was within the enamel, and activity. So these are the scores that we would use for severity. So sound enamel being 0, and the most severe one that we would use for the analysis was 3, localised enamel breakdown, no visible denting. Once you get past 3, we would exclude the subject from the study because they needed a little bit more than we could give them. For activity, we based it on that loss of lustre. An active lesion was opaque. It felt a little bit rough to a ball-ended probe. And so we could split them into active or inactive lesions as well. And we divided the tooth into 7 zones. The dark grey area in the middle is obviously where the bracket would be. The bottom incisal area, which we didn't score either, anything that we found there we didn't think was a white spot lesion. We thought it was probably some other kind of developmental lesion, so we didn't score anything in that area. And just a couple of examples. So zone 1, severity 1, you could only see if you dried the tooth. If the tooth was wet, you wouldn't be able to see it. And they just get increasingly severe as you go along. Activity is a bit difficult to show on a slide, I'm afraid. Once we had the scores, we then developed a transition matrix to assess the transitions between baseline and follow-up. And we had 3 options there. If we had a positive score, the lesion was assessed as progressing, a negative score, regressing, and if there was no change, a score of 0, we classed it as a stable lesion. And that's an example. We only gave these 3 options. We didn't grade for the amount of change within a particular area. So from 3A to 0 was the same as 1 inactive to 0. We then analysed those transition scores using a proportional odds ordinal logistic regression model, and we also accounted for clustering of the lesions. Although we did find that lesions within a subject did behave differently. They didn't all behave the same way, but we did have to account for that subject clustering. As a secondary outcome measure, we did use a QLF machine. This is a picture of Anne dealing with it. We would take this out to each practice. It's a cumbersome piece of equipment. As far as I'm aware, there's still only the 2 in Australia, and they're both at Melbourne University. The QLF is a diagnostic tool, and what it does, it looks at the autofluorescence of enamel, measures that, and from that, it gives you an idea of the mineral content of that enamel. And I'll just show you the kind of image that you get from it. Now, you can see the darker area over the top there. So that's how a white spot appears. It appears darker. And what you can do is it has some software in it which will allow you to reposition a tooth image at sequential visits. So you can see if things have changed. And I've actually got a series of images here. So this is a baseline image, and it calculates the fluorescence loss in a particular area. And this is at 4 weeks, 8 weeks, and 12 weeks. So you're having values at the top that you can use, and you can actually see the difference clinically as well, just looking at that image. It's a difficult thing to use. It's difficult to use clinically. This image here, it's a nice one. You can see the outline around that lesion. It's all on sound enamel, and the software can then calculate difference between sound enamel and what's happening in the lesion. But if you go back to this image, you can see around the top of that tooth, it'd be impossible to outline on sound enamel. You'd be hitting the gingival margin, so you can see the difference between the two. It's a lot harder to calculate when a lesion is close to the gingival margin, and that happens a lot in these trials. That's where the majority of the lesions are. So we're still looking at this data, trying to find a good way to analyse it, because our deviations at the moment are so huge. So once we've looked at this data a bit more, we'll get back to you and let you know what it says. But at that point, I think I'd like to hand over to Mike and just let him tell you a bit more about the results.
Thanks, Denise. So although we don't have results to present tonight on the QLF data, and that'll be an exciting analysis to do when we work out how to do it, we do have information on the observational data using the ICDAS scale that Denise talked about. So I just want to spend a couple of minutes, and it will just be a couple of minutes, presenting the results using that ICDAS scale of what we found with using this product at 4, 8 and 12 weeks. Okay, so baseline data, the total number of white spot lesions in these patients that we were dealing with was relatively large, 408. We did, as Denise said, control for the fact that there would be a clustering of white spot lesions in patients. We'd find more in some than others. But there was a mean number of 9 white spot lesions per subject, quite a large number. And there was a range, of course, from 3 to 19. So 3 to 19 white spot lesions per subject. And if you think about your own clinical practice, perhaps you could think how that relates to patients that you see in everyday practice. The white spot lesions were more prevalent on the lateral incisors and canines in the maxilla and on the first premolars in the mandible, and there were slightly more white spot lesions in the maxilla, about 56%, but difference is not great. It's around about half in each. This slide shows the number of white spot lesions by tooth, from 1.4 to 2.4 in the maxilla and 3.4 to 4.4 obviously in the mandible. The laterals and the canines stand out a little in the maxilla particularly as having the most number of white spot lesions around these brackets. This is the baseline ICDAS scores, looking at code 1 for severity, code 2 for severity, and code 3. So that obviously the majority of our lesions, our white spot lesions, were coded 2, and the majority, of course, were active lesions rather than inactive lesions. So we had predominantly active lesions compared to inactive, and those were code 2. This rather colourful graph just shows the progression, the percentage of lesions that progressed by week down the bottom here for all white spot lesions, and then for white spot lesions with the severity of 2 or 3 at baseline. So if we deal with all white spot lesions to begin with, you can see that the red, which is the placebo group, had had less progressions, or more regressions than the tooth mousse group had more regressions than the placebo group for all white spot lesions. When we look at severity 2 or 3, that is the more severe of those lesions, excluding the code 1s, we find exactly the same picture, but the difference is greater, and in fact it's significant, and I'll show you that in a moment. We were interested in severity 2 or 3 for several reasons. One, of course, they're more severe lesions, so we should be more interested in them. They're more likely to progress, perhaps, if left alone, into cavitation. But also, it's very difficult to in code 1 using ICDAS. The variability around the diagnosis for code 1 is quite high. So the reliability of the data is called into question, perhaps. Now, other studies have done exactly what we have, and that is looked at code severity 2 or 3, and that's what I want to concentrate on, although I will present all white spot lesions as well. Now, the best way to analyse this data is using odds ratios, which is the ratio of the odds, or the likelihood of one progressing in the group compared to another group, just like the horsies. So when you look at the odds ratio for all white spot lesions, it's an odds ratio of 1.67. Lesions were more likely to regress in the tooth mousse 1.67 times than the other. When you look at odds ratios, if they include the value 1 or unity in the confidence intervals, you know that they're not significant. So, and in fact, that's our p-value is not significant. That's for all white spot lesions. However, when you look at the severity code 2 or 3, and as I said, these are the more severe codes, the more severe lesions, the lesions that we're more interested in, we have an odds ratio of 2.5, almost 2.5. And it doesn't include 1, and the odds ratio is significant. So we've got a significant difference when we look at codes 2 and 3 for regression using the tooth mousse in this population. Here this slide just gives it a slightly different aspect, but the odds ratio here on this axis and the weeks down the bottom here, and again with all white spot lesions you can see that the odds ratio increases, but it's only when you get with codes 2 or 3 in the tooth mousse group, or you're looking at only codes 2 or 3. At 12 weeks, we have a significant difference because that bar doesn't include 1. So it's significant. When you look at codes 2 and 3, there is a significant difference between the two groups. Now, this is the first time that this has been shown in a study population of any size. So it's quite interesting information, exciting information. It's not the end. Further work needs to be done. But it's pointing in exactly the right direction in terms of a preventive agent for white spot lesions of this kind. When we look at activity of lesions, in both groups, active lesions were more likely to regress than inactive lesions, regardless of whether you included all white spot lesions or just those severity 2 or 3. So a significant difference of odds ratios very high, 7 or 5 when you looked at severity 2 or 3. So active lesions are more likely to regress than inactive lesions. And as you might recall, most of our lesions were active rather than inactive. So what we can conclude from this is using these criteria, these ICDAS criteria, and Denise put them up before, they're a little different to the old tried and true DMF-T or DMFS that we've used, but they use similar principles in a way. Using these criteria and transition scoring, which is this matrix that again Denise presented, where you look at what's happened to a lesion, whether it's progressed or regressed, using those two things, it provided a useful method to demonstrate that significantly more post-orthodontic white spot lesions regressed with tooth mousse compared to a placebo control. And we'd like to acknowledge, of course, the sponsors, the CRC for Oral Health Science that Jerry mentioned at the beginning, GC Corporation Japan, and a big thank you to the participants, the staff of the orthodontic practices involved in the clinical in this trial. It was quite an impost to have us come in, or at least Denise and her team go in, to do this study, and it's proven to be worthwhile, as I think you'll agree, that we have a direction now. We can see that this material can prevent white spot lesions, as we would theorise that it should.